Good afternoon, namaste. Such an illustrious panel, respected SP Singh sir, Ambassador. We just heard from the illustrious speaker earlier on. And it's truly a privilege to be invited here to this dais and to give this talk. When I was coming, I was thinking of joining a panel discussion so there would be more question answers, but then have this privilege to actually talk through. And I'll start from where you spoke about the ethics perspective, the regulatory perspective, which we need to look at from the data part. At Apollo Hospitals, we have been having some sort of EMR from the year 2008. Now, you can understand that we have been, in many ways, collecting the interactions that we are having with the patients, the clinical interactions that we are having with patients. Since 2008, it's been almost 14, 15 years. Now, what has that done is helped us retrospectively to build models which are, over a period of time, looking at the patient's longitudinal journey, where it would start with a simple health check, where we have his or her existing comorbidities, his normal parameters in some sense, or certain abnormal parameters, and then study them over the period of next 10 years to see where they are leading. And that has helped us in building a lot of AI solutions. Just to give you the context, we were just mining a portion of our data, about 1.5 million patients after ethical approval and, of course, signing it with the Indian Council of Medical Research. And that gave us about close to 460 million, almost 500 million data points through which we have been able to build what we call as a robust symptom checker, where we have about close to 1,200 conditions and about 800 symptoms. The idea is this, that the data in Indian context exists. There are data, we can actually use this data to identify the behavior, the pattern, the disease pattern in Indian context at this point of time. And we can build these AI models not only for the use prospectively, we can actually lead them to have appropriate validation worldwide. Because this is the time for what we call as consensus algorithms in healthcare. Nobody can say that their algorithm or the data is unbiased. We would have to always say that from any geographical, ethnic, or from any particular population, when you collect data, when you build AI solutions, they are biased. They're definitely biased. And therefore, you would now require technologists to take your AI APIs into different countries, have them validated, have them calibrated, and have them see into the other data what possibly they could do. And that is what is Make in India and Take It to Global, which is the theme of this conference, to actually build it in India and then take it. Right now, we have 5 of our AI algorithms that we have developed at Apollo, which are now being used in 8 countries and 50 hospitals. And that is the power that we have in our data systems. Of course, power which comes with also with the computing, when you can use, technologies like federated learning and others. But I want to go back to the ethics perspective. So how do you build it? How do you build an infrastructure where you would have a startup organization come and work with you? What do they need to do? And there is a simple framework that we developed at Apollo, and we call it EASE, E-A-S-E. So the first E stands for ethics, where you are looking at whatever model you build that is safe and non-malicious, then it has a good efficacy, accuracy, there is a data integrity in the way you are looking at it, it is fair and inclusive, and of course you would do whatever you can to actually debias your systems on that. The next A is about the adoption, where you have to focus on interoperability. And people who work in healthcare, they know about the interoperability standards, FHIR, HL6, and others, which are absolutely required because, in a medical record, and SP Singh sir will agree with me, that we can actually write hypertension in 20 different ways. So how do you bring in all of that together and make a meaningful use of your EMR is very, very important in that context. And then, of course, how does that algorithm that you build integrates into your workflow to give physicians the benefit for which you have actually made it. I see a lot of algorithms that are built which do not integrate with the workflow, the clinical workflow, and therefore they are, even though they are possibly very high in precision, recall, or their accuracy standards, but they are not able to make it to the level where the people would use them. The other point in the S is about suitability, the perspective of what is the question that you are trying to solve from a public health or from an individual perspective. You would have to understand that particular thing very comprehensively and then go about and looking at it. The other thing that comes out, and I was working on a draft recommendation for World Economic Forum on chatbots and conversational AI. And we had a very distinct thing about in any conversational AI, and this does not only go for healthcare, but also goes for even the defense that they were talking in the morning. How does human give handovers to machine? And how does machine gives handovers to human? And this is an area of research that we would have to look at and understand it comprehensively to bring AI into healthcare in the correct perspective. Lastly, the question about the explainability. If you are not able to make your model explain to the doctor, he will not be able, or he or she will not be able to make it explain to the patient. And therefore, you will have what we call as a trust deficit in the system, and therefore, you will not have a practical implementation of the AI. Therefore, it is very important that you build models which are explainable. I think in the previous discussion, they were talking about EX AI. And it is so important to bring the concepts of EXAI, digital twin, and others that we've seen in defense technologies to healthcare. I would like to end by giving you 5 questions. And these 5 questions, wherever I go, wherever I speak, I actually talk about these 5 questions, even to my students at IIM and ISBs and IITs. You would have to change the narrative around the AI from AI as a substitute to AI as a complement. In healthcare, we have done it wrong by saying an AI tool can actually be better than a radiologist by this percentage. Of course, in a paper you can write that, but the media takes it in a different way, and then the doctors become apprehensive in using it. The second question is, how do you build data consortium? That was your questions about how do we share data? How do you build data consortiums, not just only for data, but also for the insights that you are getting out of the data, and how you build that in that way. And in building data consortiums, you would be using confidential computing, because you need to do this by preserving the patient's privacy, security, and confidentiality of their data. In doing that, one of the biggest hindrance that we face is the cost. How do you then have a conversation with your cloud providers to reduce the cost so that you can get that level of computing? And for the customer work, or for the perspective, and this is the 4th point, about how do you do disruptive innovation in healthcare in that way? How do you bring digital entities? How do you bring digital identities? How do you bring digital twin in concept of AI in healthcare, particularly when it is evolving to Web3 and metaverse? And finally, for the science. For the science, you would have to look at how are you going to build attentive machines in long run, where the conversation is changing to the 4 P, the Ps, what we call as the percepts, environment, actuators, and sensors. If that environment is changing, how are you then prepared for taking your medicine into the next frontier? Thank you very much.